Hi, this is Dr. Bhargava, and this video is the next in the series of body imaging case review. Our first patient presented with abdominal pain, and we performed a CT of the abdomen and pelvis. And we see here on the multiple images the characteristic findings from epiploic appendagitis. So epiploic appendages are next to the colon. They can get inflamed, and the inflammation can look like this, where there is a central dot, and in other projections, you will find that the central dot becomes linear. So this is the thrombosed vein, and there is some loculated fat stranding around it. So don't confuse it with diverticulitis. This is epiploic appendagitis. Here is our next patient, and we have performed a dotatate PET CT to evaluate their neuroendocrine tumor. And we will start by reviewing their rotating image. We know that they have neuroendocrine tumor, and we know that they have metastasis to the liver, where we see a focus of increased uptake. And that finding is seen right here. We see physiologic uptake in the pituitary, salivary glands, uptake in the spleen more intense than the liver, and excretion from the kidneys into the urinary bladder. On the cross-sectional images, we find that the liver is steatotic, and generally the tumors are hypodense, but because the liver background is so hypodense from steatosis, the tumor is appearing as hyperdense. So remember, the appearance of a tumor in the liver on CT and MRI images depends on what the background liver looks like. And the tumor usually, like I said, are hypodense, may appear hyperdense if the surrounding liver shows steatosis and is hypodense. The interesting finding here is, look at this focus in the pelvis. This corresponds to this very prominent uterus. On the CT, we don't see any focal lesions, but we know that CT is not good for focal lesions in the uterus a lot of times. This was evaluated further, and it turned out to be a incidental endometrial cancer in this postmenopausal woman. So here is the uterus on a CT. We see endometrial thickening, and that endometrial thickening is seen right here. That is the endometrial cancer. This is the myometrium that I'm outlining right there. So an incidental endometrial cancer that was picked up on a dotatate PET CT in a patient with neuroendocrine tumor. This is our next patient. They have had a surgery and a colostomy, and we see a complication from colostomy where the loop of the bowel that is supposed to open outside on the skin is now hanging outside the abdomen along with its regional mesentery. And so here we see prolapse of the colostomy loop outside the abdomen. And so when you see this, let the surgeons know that this has happened and the loop is hanging outside the patient, which is called a prolapse. Here's our next patient, and we were suspecting a urinary bladder rupture. And to evaluate urinary bladder rupture, the best scan or study to do is a CT cystogram, where we place a Foley catheter, we inject contrast, we clamp the Foley, and then we acquire a CT of the pelvis or CT of the abdomen and pelvis to see if the contrast extravasates through a defect in the urinary bladder wall in the intraperitoneal or the extraperitoneal compartment. So here we have done that, and we see a defect with contrast extravasation. This is the transaxial image showing the Foley bulb inside the urinary bladder, and this is a defect in the superior wall of the urinary bladder with extravasated contrast in the intraperitoneal compartment and around the liver going up to the subdiaphragmatic space. And so this patient was diagnosed with intraperitoneal rupture of the urinary bladder. This is our next patient, and here we find that there is a loculated pneumothorax, and we find that a part of the lung is herniated outside the chest wall. See here, we see more focal air outside. Maybe they've had an intervention because that can lead to something like this. So a herniated pneumothorax, a rare complication for which the treatment is surgical. This is our next patient, and here we are looking at plain films of the abdomen. The finding here is soft tissue emphysema, which is seen as a low density focus or lucency in the abdominal wall. Soft tissue emphysema in the abdominal wall is most often due to a recent surgery, or it could also be due to an infection from a gas-producing organism such as fasciitis or necrotizing fasciitis. This is a companion case showing fat as a lucency in the subcutaneous space. Symmetric. Here's our next patient. We're looking at a single image, a plain film of the chest, and they've placed a Dobhoff tube, and as we trace the Dobhoff tube from the distal to the proximal part, we find that it loops in the esophagus. And so when you see something like this, let them know that this needs to be removed and another tube needs to be placed. This is our next patient, and here we are looking at two images from the ultrasound of the thyroid. We see the left lobe of the thyroid, and inferior to the left lobe of the thyroid, we see this focus. This focus has some blood flow on the color Doppler image, and something like this is very concerning for a parathyroid adenoma. We know that the two pairs of parathyroid glands, superior and inferior, are closely associated with the posterior aspect of the thyroid. And this focus here is at the inferior pole of the left lobe of thyroid, posterior to it. This is the parathyroid scan from the same patient on the early images acquired about 5 to 10 minutes, up to 15 minutes after the injection of about 20 millicuries of technetium-99m Cestamib. We see asymmetric increased uptake in the left lobe of the thyroid. The quality of the image is not very good, but sometimes that's what we get. And on the delayed images, we find that the normal uptake in the right lobe of the thyroid has washed out, but there is persistent focal uptake in the left lobe of the thyroid, which corresponds to this focus that we saw earlier, posterior to the inferior pole of the left lobe of thyroid, consistent with the parathyroid adenoma. Here is our next patient, and we have two set of plain films on inspiration and expiration showing an enlarged cardiac silhouette, prior changes of sternotomy, a left chest wall cardiac device with two leads. And between the two images, we find that on inspiration on the right side, the diaphragm has moved down compared to expiration, but on the left side, the position of the diaphragm is the same between inspiration and expiration. And so that tells us that this patient has had a diaphragmatic paralysis. The most common cause of diaphragmatic paralysis is prior coronary artery bypass grafting, and we see the changes of CABG in form of sternotomy in this patient. These are correlative images from the patient's CT scan showing elevated left hemidiaphragm from paralysis. Here is our next patient. We have performed a barium swallow, and we find that this patient has a prominent cricopharyngeus muscle seen here, a small esophageal web seen here, and also the contrast. I don't have the dynamic images to share, but when they swallowed, there was a reflux of contrast into their nasopharynx, and we don't see it clearly, but some of the contrast is tracking superior to the palate. This is the level of the palate. It's going like this, superior to the palate, and dripping down from their nose. So sometimes we see this reflux, and we have to report it. So look out. It's not a very common finding, but once in a while you may see some reflux. Here is our next patient. Also looks like a parathyroid scan where we have early images showing uptake in the thyroid and asymmetric focal uptake at the superior pole of the left lobe of the thyroid, and the delayed image acquired up to 2 hours later after the administration of technetium-labeled Cestamib. The uptake in the thyroid has washed out. Focal uptake persists at the superior pole of the left lobe of thyroid, consistent with the parathyroid adenoma. And here are the images showing on the ultrasound the parathyroid adenoma, where it was localized, measured, and color flow demonstrated inside it. This is our next patient. They presented with fever and chills, a young female of childbearing age group, and on the MRI on the top we have small field of view, T2 weighted images, axial, coronal, and sagittal, we find that there is a slightly complex T2 hyperintense cystic focus with thick walls, some internal debris, and it shows low T1 signal, and post contrast it shows a lot of enhancement. So there is capsular enhancement and there is surrounding fat stranding. So putting everything together, especially the clinical aspect of patient presentation, fever and chills with high blood cell count, we made a diagnosis of a tubo-ovarian abscess. Here's our next patient, and we performed a barium swallow looking for a leak post-op. We see that an NG tube is in place. Whenever an NG tube is in place in this procedure, we have to report it in the findings. We see some post-surgical changes here, anterior to the esophagus. The finding of a small leak is seen only on the AP projection. So these findings of leak can be subtle, you have to pay attention, and sometimes they may not be seen on the lateral projection where most images are acquired, but you have to acquire one or more set of images in the AP projection as well where you may find a leak. And so this was a diverticulum that was repaired in this patient, and post-repair we found a small leak. This is our next patient where we have performed a MRI of the pelvis in a female, and we see part of the endometrium here. Your uterus appears to be retroverted there. Here's the urinary bladder, T2 hyperintense urine inside. Well, maybe it is seen right here. This is a focus that is T1 hyperintense and shows no enhancement, so that's an endometrioma. This is a focus that is T1 hypointense, shows some peripheral enhancement, also seen right there. That's probably a corpus luteal cyst or a developing follicle. And so an endometrioma and a benign cyst in the right ovary. Endometriomas are generally T1 hyperintense, T2 variable. They may show restricted diffusion and they may have some capsular enhancement. The characteristic finding that is described in the literature, although may not be seen in all the patients, is a T2 shading, which some of it we see here. From non-dependent to dependent portion, there is a decrease in T2 signal. That's called T2 shading. This is our next patient. They presented with pelvic pain, a young female of childbearing age group. We performed a pelvic ultrasound. Here we're looking at two transvaginal images. We find that in the long axis view of the left ovary, there is a complex cystic focus with internal some irregular echogenicity, which does not show any color Doppler signal. And so this is a retractile or a retracting clot inside a hemorrhagic cyst in the left ovary. So in this situation, you want to make the diagnosis on a pelvic ultrasound and ask for a follow-up in 6 to 8 weeks to make sure that it has resolved. Usually these things resolve over a period of 1 to 2 cycles. Here's our next patient, and I'm showing you on the top coronal and axial T2 weighted images. There is a tumor in the liver with a central scar. The tumor is slightly hyperintense on T2 compared to the surrounding liver. The internal scar is more T2 hyperintense. On the contrast enhanced images at the bottom, these are T1 fat saturated images. We find that on the arterial phase, there is no enhancement. On the portal venous, there is centripetal enhancement. And on the more delayed image, there is peripheral centripetal fill in. And so these findings are consistent with a hemangiomas. So hemangiomas, remember, can have a central scar. The other pathologies or tumors that you can see in the liver that can have a central scar are FNH or focal nodular hyperplasia. Also, fibrolamellar variant of hepatocellular carcinoma or HCC can also have a central scar. Here's our next patient. We have performed an FDG PET-CT scan, and we will start by looking at the rotating image. We were looking for recurrent breast cancer in this patient, and you can see that there is a large focus in the superlateral aspect of the left breast, and that finding I'm going to highlight right there. They have on the cross-sectional images a breast implant, and they've had a prior surgery, and now we see this soft tissue density mass in the superlateral aspect of the left breast, which is intensely hypermetabolic, consistent with local recurrence or metastatic disease, because an axillary lymph node can look like this also. The interesting finding is that here we found incidentally pneumoperitoneum. That's subdiaphragmatic air, also seen right here. And the cause of that was found on the CT images right here. We see the colon, we see diverticulosis, and we see a focus of free air. So this patient, and a focus of FDG uptake from inflammation secondary to complicated diverticulitis. So this was picked up incidentally on a whole body FDG PET CT scan. Be aware these findings are there. You have to pay attention to the CT that comes as a part of the PET CT. It may be low dose, it may be without contrast. It's very limited, but make sure you don't miss such findings. This is our next patient, and here we are seeing findings suggestive of a intersusception seen here on this axial image, coronal image, and also on the sagittal image. This intersusception is probably not clinically significant because we don't see signs of bowel obstruction. The bowel is not dilated, so and no definite lead point is visualized. And this was a finding that was picked up on a patient who presented with abdominal pain, and a follow-up colonoscopy was recommended. Intersusception is usually secondary to a lead point, which is either a lipoma or a tumor such as an adenocarcinoma. Sometimes it can be just transient without any lead point seen on endoscopy or imaging. And transient intersusceptions do not produce bowel obstruction. They are just seen incidentally on imaging. And if you repeat imaging a few hours later or a few days later, they will not be present. So this was a colocolonic intersusception, and the patient was referred for a colonoscopy to look for or see if there is a lead point that led to this intersusception. This is a patient who presented with constipation, and we can see here that the sigmoid colon is markedly distended with a lot of stool. The wall of the colon is thickened with enhancement, so they probably have some colitis going on there. So this is a case of very severe constipation seen on CT. Thank you for watching.